Welcome everybody to the M2 test for risk of miscarriage webinar. I'm Dr. Robert Anderson from the Southern California Center for Reproductive Medicine and Ovation Fertility Group, and I'll be your moderator today. I think we have a fantastic program for you on the M2 haplotype and its application for testing. I've been personally using the M2 test in my practice, not only for evaluating patients with a current pregnancy loss, but also in situations where an IVF pregnancy has miscarried after we transferred a single euploid embryo. And we've also started to use it in implantation failure cases where a euploid embryo has been transferred. But I think you're going to find from our presentations today that the applications for this test may be even more widespread than that. So the format today, we have 3 speakers. Each will give a presentation followed by some time for questions. And at the end, after we sign off, we just ask that if you could, there's a short survey to fill out. If you do that, we'd greatly appreciate it. So our speakers today, first off will be Professor Simon Fishel, who's the founder and president of the Care Fertility Group in the UK, and also a professor at the Liverpool John Moores University. Simon will be speaking about the clinical utility of testing for the M2 haplotype. He'll be followed by Bhavini Rana, PhD candidate at Rutgers University and a field application specialist for genomic prediction, and she'll give us the details about the development of the test for M2 in the embryo and the adult. And lastly, Dr. Nathan Treff, the co-founder and chief scientific officer for genomic prediction and also the director of their clinical laboratory there, will give us some human population data of the M2 haplotype. So with that, let's start our program. First up, Professor Simon Fishel, speaking about the clinical utility of testing for the M2 haplotype. Simon?
Good morning and good afternoon, and thank you very much for joining us today for this particular webinar, where I'm going to discuss the annexin A5, as it's known, the ANXA A5 M2 haplotype, and particularly its clinical implications and risk factor for miscarriage and placenta-mediated pregnancy complications. As we can see, over the years since the inception of IVF at the end of the 1970s, 78, the first baby, and then into the 80s, where we had low success rates, defined as any way you like, but particularly live birth rates and live birth rates per embryo transfer or embryos transferred, has been a steady improvement. And that improvement has really taken us to very high levels currently in certain situations. But we can see here that there is a range, even where we get these high levels of live birth rate. In some clinics, it's not the same across the board. This rectangle here really looks at what we see in the UK, for example, where in the UK and the US we have good audited data. There is a big range in live birth rates, from the clinics producing top results to those producing lower results. And we often get comments associated with that, such as, well, we see different patients, or we can't select patients, other clinics can, or we use safer protocols, which means that we're not likely to get as good results. Whatever the situation is, we actually end up with, in the UK and the US data, of a national average of around about 25 to 28% live birth rate per embryo transfer, or even per cycle started or intention to treat. And yet some clinics are getting way more than that. From my personal perspective, I think one of the real reasons why we've seen improved live birth rates over the years is improvement in practice. And particularly for me is attention to detail. I think that's always been critical. But importantly too, there have been technological advances, and the appropriate use of technology in certain situations has definitely improved live birth rates. But I think taking it further into the higher levels and getting beyond even the 65 to 70% that some clinics are getting, we probably need to go on to personalized strategies to be able to stratify the patients according to their need. Hence this particular webinar today. So if we take even just the top clinics, where they're getting 60 to 70% live birth rate, we still have the issue of those patients who miscarry and those who have placenta-mediated pregnancy complications. And that term includes things like intrauterine growth retardation, small for dates babies, prematurity, preeclampsia, for example. Now, we now have established molecular-based risk factors for recurrent pregnancy loss. The big one, of course, we all know about is aneuploidy, but we also have the inherited hypercoagulation disorders, such as factor V Leiden, factor 11 prothrombin, and they give an associated risk of 3 to 6 times of miscarriage. The antiphospholipid antibodies, anticardiolipin antibodies, lupus coagulant. As we know, these are the thrombophilias, which we test for because they are a risk factor. Now, annexin A5, the ANXA5 protein, is a very important protein in terms of coagulation. And what's absolutely essential is when the pregnancy is being established, we know that there is remodeling, very precise remodeling of the uterine spiral arteries. And it's very important that they remain healthy and the blood flow is smooth during that respiraling to prevent the malfunction of that placenta and eventually leading to placenta-mediated pregnancy complications. So prevention of clotting during that remodeling of the uterine spiral arteries is essential. And this is where annexin A5 comes in. It's a phospholipid binding protein. It has potent placental anticoagulant activity, and this has been known since 1990. It's present on the apical surface of the syncytial trophoblast. And in addition to its ability to minimize the chance of clotting, it's also essential for repair and maintenance of the syncytial trophoblast, which is essential for the early establishing of that placental unit. The gene for the annexin A5 protein is found on chromosome 4q27. And there have actually been 2 particular haplotypes that have been discovered from Bogdanova's group published in Human Molecular Genetics in 2007. There's the M1 haplotype, where we can see here that 2 particular mutations where an A is mutated to C or a T to a C. But there's the M2 haplotype, which is really of our particular interest, which has a 4-point mutation where G is mutated to A to C, T to C, and G to A. And you'll hear more of this a little bit later in the talks. But it's this M2 haplotype, and what we know about that since 2007 and where we are today that we're going to discuss here. So let me do this by way of summary. What do we know about the M2 haplotype? Its frequency is significantly higher in recurrent pregnancy loss patients. This we now know, this has been established. But we know that its presence is in different incidence in different ethnic populations. We know, for example, it's about 11% in fertile Japanese controls, but 21% in the recurrent pregnancy loss patients from the publication of Miyamura in 2011, Miyamura and colleagues. But if we look at the European control populations, we know it's about 15% in the average population, increasing to up to 34% with recurrent pregnancy loss. We also know it's associated with preeclampsia, gestational hypertension, fetal growth restriction, and small gestational age newborns from various studies. The M2 haplotype has also been studied in relation to the male and female gamete. So that's the sperm and the egg, and the placenta, in a study by Dimitru and colleagues in 2015. This is Professor Leslie Reagan's group. Professor Leslie Reagan is a professor of the Royal College of Obstetricians and Gynecologists in the UK and Imperial College London. And they had this trio study, and they concluded that the M2 haplotype is indeed a separate risk factor to known risk factors, such as the antiphospholipid syndrome, factor V Leiden, and the prothrombin mutation. Importantly, it confers same relative risk to carriers of both sexes. And I think that this is, without doubt, the first time it's been established that there's a gene mutation from the male that can bring about placental malfunction. And also having one or more M2 alleles in their study in combination with other risk factors further increases risk that they found. You know, in our two publications based on IVF couples, we found that it was present in the male in an incidence of 26% and in the female at 24%. The risk of both partners carrying it we found was 10%. So couples had an incidence of 44%. We also found that it coexisted with unexplained infertility at an incidence of 37% and with PCOS at 35%. But what's important is we know that we can provide a treatment to normalize any risk, which is low molecular weight heparin. And for those of you who are interested, as we can see here, the dose that we used in our studies was subcutaneous 40 milligrams daily, beginning on the day of oocyte retrieval for fresh embryo transfer, and on the day of frozen embryo transfer for a minimum of 12 weeks. It's also recommended for women who are carriers of the mutation to continue after pregnancy, probably 6 weeks post-delivery, due to the risk of thromboembolism. When we looked at our data on the outcomes of miscarriage for the untreated M2 carriers, you can see in this slide that it occurred at different stages, but not beyond 12 weeks. And this correlates to what Dimitri et al. Found in the paper of 2015, that the M2 haplotype is a risk factor for early spontaneous abortions before the 12th week of gestation. And of course, an important point here is we don't know how much damage is being done even earlier. Probably the damage is being done very early. And this is where IVF is unique, in that we can capture these patients very early on in the attempt to establish the pregnancy, whereas most of the studies have been done on couples conceiving naturally when the placenta is already well underway and the damage has occurred. Interestingly, when we looked at the clinical miscarriage for treated M2 carriers, then in that particular group of 43 clinical pregnancies, we had 91% live births, and the actual miscarriages we had was one at 15 weeks due to chorioamnionitis, one at 23 weeks, which was a Dandy-Walker variant of a twin pregnancy, and there were two others where we didn't have a diagnosis. So in summary, the ANXA5 M2 haplotype is transmitted equally by males and females, and it's where some studies have come unstuck because they've never looked at the male. It acts via the embryo, therefore its effect is embryonal, and also via maternal disturbance in normal annexing function in female carriers. The other well-established thrombophilias are only maternal, and their incidence is far less in the general and in the IVF populations than the M2 haplotype. And the established thrombophilias exacerbate the ANXA5 M2 haplotype effects if present in the female. Carriers of ANXA5 M2 haplotype have a 2 times higher recurrent pregnancy loss risk as compared to the general population. But if the risk of miscarriage is threefold when the number of miscarriages is taken to be 3 and above. As you know, recurrent pregnancy loss tends to have 2 definitions of whether it's 2 or 3. There's a 4-fold increase in the risk of early pregnancy loss compared to fertile controls. There's a 2 times increase in risk of gestational hypertension and fetal thromboembolism, and preeclampsia. And there's a 3 times increase in the risk of restricted fetal growth. There's a 2.6 times increase in the risk of small for gestational age, and a 3 times relative risk to develop antiphospholipid antibodies. And we know that exists or coexists in over 30% of the PCOS population so far studied. So, in conclusion, the M2 haplotype is a risk factor for pregnancy loss or placenta-mediated pregnancy complications. And what we don't know is, of course, how many patients, for example, who are coming through IVF may be at risk of this without actually screening first, because it may well be that losses happen earlier. We just don't know at this stage. But what's really critical is the screening of both genetic parents. So in fact, if one is doing egg donation or sperm donation, if one can, one should really try to screen both the egg and the sperm donors as well. And so it's the genetic parents in the couple seeking attempted pregnancy need to be screened. And the beauty that is now happening with genome predictions work is that it's simple via a simple saliva test, whereas before it used to be with blood. Treatment is also available, which is critical if you're going to do a test, and there needs to be some resolution. Otherwise, what's the value of the test? And we know that giving low molecular weight heparin normalizes risk. IVF, as I've said, uniquely offers a chance to provide treatment early. And I think this is where we will learn an awful lot more and be able to do an awful lot more support for patients, particularly those who've experienced miscarriage, if we can screen and then go in early. The M2 disorders are embryonal. It's something that we mustn't forget, hence the dependence on transmission of carriership. And this is where it's been absolutely crucial, the work that genomic prediction has done in recent years to enable us to study this in the embryo, because that will give patients another opportunity as well. And because we can enhance our focus on the embryo, not just on the carriers, and provide treatment only if it's absolutely necessary, especially as it being daily subcutaneous low molecular weight heparin. The genome prediction test also can uniquely combine aneuploidy screening and M2 status. And we can all see the importance of that when looking at potential miscarriage or recurrent pregnancy loss patients. So overall, the really big point here is that it allows us to stratify our patients. We detect those who have a risk, and then if we have a risk, we can establish whether the risk is more imminent or not by studying the embryo if we wish to. But in any event, we only offer treatment to those whose risk has been established by the simple buccal swab test of knowing whether they're carriers or not. Thank you very much. And now I'm delighted to introduce Bhavini Rana, who is going to talk to you about the development of both adult and embryo testing. So over to you, Bhavini.
Hello, everyone. Thank you for joining us today. Thank you, Professor Fishel, for describing the clinical utility of the M2 haplotype. On behalf of Genomic Prediction Clinical Laboratory, I will be discussing the development of the M2 test for adults and embryos. First off, I will be going through the development of the adult M2 test. As Professor Fishel mentioned previously, the M2 haplotype consists of 4 base pair mutations located in the core promoter of the annexin A5 gene. We see here, indicated by the arrows, the 4 loci of the allele in which the M2 haplotype is present. Our test development was really centered around genotyping the M2 haplotype in patients to confirm the presence or absence of the variant to help facilitate patient care. Currently, to test for M2 carriership, sample collection involves intravenous blood draws, which are inconvenient for patients and often uncomfortable. With the development of our new M2 adult test, Sample collection is fast and easy with an at-home saliva collection, which can be performed within minutes. Conventional genotyping methods for the M2 haplotype involves Sanger sequencing, which is expensive, time-consuming, and involves a cumbersome data analysis. With the development of our new methodology, qPCR is utilized. It is less expensive, relatively fast, and requires a simple analysis compared to that of Sanger. Results are typically available within the same day of sample preparation. Our current adult M2 workflow involves a saliva collection, which patients can do at home or the clinic. Once the samples have been received at the lab, DNA is extracted and subjected to an in-house qPCR protocol. An automated analysis is completed through our M2 pipeline, and a report is generated. We disclose M2 carriership as positive or negative for the presence of the variant. Here is a look at the data analysis portion of our workflow. It shows the results for an M2 carrier from qPCR here on the left and Sanger sequencing on the right. The qPCR results are much easier to interpret. The sample is heterozygous for the 4 SNPs of the haplotype, which can easily be seen as indicated by the purple dots on the graph. Compared to qPCR, Sanger is much harder to interpret. At the 4 SNP positions, we can see the presence of both alleles indicated by the arrows. However, filtering through the sequence output and locating the SNP of interest is often time-consuming and harder to detect. Our qPCR methodology also shows concordance to the results that were obtained through Sanger sequencing for this particular sample. Our validation for the adult M2 test was submitted as accredited by CLIA and CAP. Our next focus was really to develop and validate an embryo M2 test. In a study conducted by Professor Fishel in 2016, they had showed the clinical utility of testing for the M2 haplotype. There was a significant increase in clinical pregnancy rates of M2 carriers who had been undergoing a low molecular weight heparin treatment compared to M2 carriers without treatment. When an effective intervention is available, it is important to screen patients for the M2 haplotype to increase favorable pregnancy outcomes. We know that low molecular weight heparin intervention works to mitigate the effects of the M2 haplotype as seen previously. However, the M2 haplotype is embryonal and particularly affects embryonic coagulation. So another option is to directly test the embryos as the haplotype impacts the embryo directly. We currently offer a set of tests under our LifeView PGT platform where we can screen for aneuploidy, structural rearrangements, monogenic disorders, and polygenic disorders. Dr. Nathan Treff will be presenting at the International IVF Initiative next Tuesday, August 11th, if you are interested in more information about our LifeView platform. M2 haplotype testing can also be integrated with our LifeView PGT platform. We would be able to report on M2 haplotype carriership in addition to results from our aneuploidy, structural rearrangements, monogenic, and polygenic testing that may be ordered. Our PGT M2 workflow involves the receipt of embryo biopsy samples at the laboratory where they would undergo an in-house developed amplification protocol. An aliquot is taken from that amplification product and undergoes our standard qPCR protocol, and it can be integrated with our LifeView PGT platform through SNP array linkage analysis, where we would be able to report both the karyotype and M2 carriership for the embryo. Our objective for the development of the test was to be able to genotype the M2 haplotype on limited quantities of DNA. So a trifectodrome biopsy usually consists of 6 to 7 cells, which yields low DNA concentrations. So performing the M2 haplotype testing on embryo biopsies with the same accuracy as on larger quantities of DNA was challenging. We performed a set of experiments to validate the use of our PGT M2 platform on biopsies. Here we show the concordance of 4 different ways we validated the platform. We first considered mimicking our sample type. So cell lines were prepared into 7-cell aliquots and results were compared to corresponding genomic DNA. qPCR results were compared to Sanger results with a 100% concordance rate. We also tested embryo biopsies in which we had DNA that was isolated from embryonic stem cells. qPCR results were compared to Sanger with a 100% concordance rate. In order to confirm our embryo results were expected of true Mendelian inheritance patterns, we evaluated familial cases or trios. Parental DNA was analyzed using our adult M2 test, and embryos were run using our PGT M2 platform. We were able to confirm our qPCR results on embryos against the Mendelian inheritance patterns based on the parental genotypes. Samples were 98% concordant to expected values. However, when SNP array linkage analysis was considered, samples were 100% concordant. Lastly, we validated the use of our SNP array methodology as part of our LifeView PGT platform. We reanalyzed clinical samples with reported qPCR results on SNP array with a 97% concordance rate. It is important to test the embryos as the M2 haplotype is considered embryonal. Testing potential parents, may indicate the probability of the likelihood an embryo may be a carrier. However, there is also a chance it may not be. The use of PGT M2 is a method for embryo selection as opposed to universal treatment of low molecular weight heparin based on the parental carrier status. We can also incorporate our aneuploidy screening in conjunction with our M2 haplotype screening. Here's just an example how we can report the integration between the M2 screening with our aneuploidy results. Our validation for the PGT M2 test was submitted as accredited by CLIA and CAP. I would like to thank our entire team at Genomic Prediction, our computational biology team, our molecular genetics team, and also to Professor Fishel and his colleagues at Care Fertility, as well as our patients and clinical providers. Now, I would like to introduce Dr. Nathan Treff, who will be discussing population studies of the M2 haplotype.
Okay, great. Thanks for the introduction, Bhavini. I'm going to kind of shift gears a little bit from the translation of the molecular genetics to clinical use and talk about some future work with regard to research around M2 carrier frequency in a variety of populations. We already heard a little bit from Professor Fishel about the frequency of this M2 haplotype in various populations. And I've kind of summarized that data here, specifically looking at females. In one study published by Professor Fishel, they found a higher frequency in the IVF population compared to the general population. And there are also several other studies that have focused on recurrent pregnancy loss. And these have been done in a variety of populations, including Europe, Japan, and South America. In general, they show a significant increase in the frequency of the M2 haplotype in cases compared to controls. The sample sizes were relatively low, from about 70 to 533 in each of these studies. One of the most important resources for our company in terms of available data is from the UK Biobank. There are 500,000 genomes that have been published, including over 400 billion SNP genotypes. The platform that's used in the UK Biobank to look at this includes over 820,000 SNPs per individual. And so we were interested in looking at whether or not we could characterize the M2 haplotype using this data. The UK Biobank, again, is a really important resource. It's led to the development of 2,769 publications to date. Unfortunately, when you look at the data that's available, there's no direct M2 haplotypes. And it actually illustrates one of the challenges with this mutation, set of mutations, is that it actually is difficult to obtain genotypes directly, and why we spent time developing the molecular genetic assay for diagnosis on adults and embryos. One of the things that people have used in the past is what's called imputation. We don't normally think about this in our field with pre-implantation genetic testing, because we often have trios where you can use parental data to directly predict, based on Mendelian inheritance rules, what is present in the embryo using linked markers. But you can also utilize reference genomes, for example, the 1000 Genomes Project, and I've tried to simplify the sequence here so that you can imagine in a reference genome where the M2 SNPs are directly measured, there may be markers nearby, which we refer to as linked SNPs, that could actually be used to what we call impute the sequence of the M2 locus without actually directly measuring it. So, for example, in the UK Biobank, where it's not directly measured, we can instead look at these linked markers and impute what the genotype might be for the M2 locus. Imputation is really based on how closely linked neighboring SNPs are to the site of interest. This is the actual map for the M2 locus. And where you see the dark red positions in the map, those are SNPs that are highly correlated with actual genotypes for the M2 locus. So there's several positions nearby that can be used to impute the M2 genotype. One of the things we did was to ask how accurate imputation is, and so we had a sample set of 116 individuals with both direct qPCR-based measurement using the adult testing strategy that Bhavini described. And we also had the 800,000 SNPs from the UK Biobank array. And what we did was to ask what the concordance between the two was. And in this data set, we found a 97% concordance, which means that we could potentially use imputation to predict M2 carrier status in the 500,000 individuals in the UK Biobank, which we were excited about in terms of being able to then look at potential phenotypes that might be associated with the M2 haplotype in a large population. One of the first observations was that we observed a 22% overall carrier frequency in both males and females. There are several available phenotypes in the UK Biobank. I've just included a subset here that are relevant to phenotypes associated with or known to be associated with M2 haplotype carriers. You can see the sample sizes to the right. And so, for example, we were able to identify a significant difference in the carrier frequency among individuals who had a phenotype including severe preeclampsia compared to those that did not have severe preeclampsia, which actually illustrates really the power of being able to look at large sample size to characterize a phenotype that might not be that common. One of the challenges that we face, however, with this type of data, and both Professor Fishel and Bhavini described this, is the fact that the phenotype is really at the embryonic level. So most of the studies that have been done have really just been to infer what the embryonic genotype might be based on parental genotypes. And in the UK Biobank, for example, we have even less information. We, for example, have individual genotypes, but we don't know the genotypes for the partner or in any particular pregnancy or embryo that they might have produced. So for example, here you have a heterozygous individual, but because we don't know the partner's genotype, we also don't know what the embryo may or may not have inherited in these cases. In a situation where one individual is homozygous, we do actually know that there's a 100% chance that the embryo is at least a carrier of the M2 haplotype. And then when an individual is normal, again, we really don't know because we don't have information on the partner or the embryo itself. So it makes it difficult to look at association studies without additional information. It also illustrates the importance of some of the work we're doing to incorporate the ability to test the embryo's genotypes directly. And as you can see here, overall, the one group that we do have certainty in terms of inheritance in the embryo is a relatively small percentage of the overall population. So homozygous individuals represent about 1.3% of the population. So what I've shown is really the current challenge that we have, which is related to being able to stratify adults without known embryo status in order to look at these associations in more detail and in larger populations. And I think one of the things that it also illustrates is the need for more detailed information on reproductive histories for these individuals. And of course, the ability to know with certainty what the genotypes are in the embryos that are either transferred or within ongoing pregnancies. So this is something that we plan to have available in the future with the incorporation of the testing that Bhavini described earlier. I'd like to thank again our computational biology team, and in particular Lou Lello, who developed the imputation-based analysis, Ed Messick, who's done a lot of work developing an accurate way of interpreting the SNP genotyping data, as well as Josh Yu, who oversees our entire technology development. And within the molecular biology team, I'd like to thank Diego Marin and Bhavini Rana, who've been heavily involved in the M2 test development, along with Ray Zimmerman. And then again, Diego for coordinating this entire webinar. And finally, I'd like to thank Professor Fishel for his involvement and guidance in development of this new technology. Thank you again for all of you who have attended the webinar, and I'm going to send it back to Dr. Anderson to field questions.
Thank you, everybody. Those presentations were extremely informative, and I think we can all see the clinical relevance of this M2 haplotype test is very significant. At this point, I'd like to field any questions that you might have. Just type them in where you see on the field and direct them to whatever individual that you're interested in asking, and we'll do our best to respond. First question, do you only need a blood sample from the patient? Simon?
Well, now we don't. That's the beauty of it. It's a buccal swab, and so it's extremely easy. And I'm sure Nathan or Bhavini would like to come in on this, but that's been really transformational for us, being able to just move on from what we've been doing for years and everybody else having to use a blood sample to a simple buccal swab.
Yeah, just to build on that, we just need a saliva collection, so it's a lot easier now to test patients versus the blood draws, which were uncomfortable and most patients, have issues with. So.
In a way, it makes, if I may just come in, it makes it all so much more important and significant too, because there was not a lot understood, and that's what this webinar is about, to try to help clinical facilities and patients understand why they might go through this test. But to have it as a blood test was that bit more invasive. Now with simple saliva test, and what could be of incredible significance in terms of what one can find out in terms of whether the haplotype is carried or not. I think it makes it simplicity and importance married together, if you like, into a new opportunity for us.
Next question, is this test indicated only for recurrent pregnancy loss patients or any patients seeking fertility treatments?
Well, if I may come in here, I think this is a very good question, and I think this is something that we'll clearly answer in more detail as the years go by. But I'd say there are two significant answers. One is, obviously, it is very clear now from over 20 publications that there is a link in recurrent pregnancy loss to this particular haplotype. Therefore, it should be mandatory if you consider that the patient may have a recurrent pregnancy loss issue. But of course, there is the other question to consider, especially when they're going through IVF, is whether or not it ought to be offered on the basis that it is probably one of those tests, now that it's simple, to do at the beginning to find out that there isn't a risk, rather than later if miscarriage occurs or any other placenta-mediated complication. And as part of that, what we don't know is recurrent pregnancy loss has a clinical definition, but whether there's an earlier loss, which is possibly likely due to some issues, and maybe we know there's an allele dosage effect. Maybe if it's a homozygous case, then there may well be a stronger effect earlier in the spiraling formation of the spiral arteries. Then it may well be that we are already preventing a problem when we didn't know it was going to be there. So there are some of my colleagues who I've debated with who argue that actually we should now be offering it to all IVF patients. Doesn't mean that they're going to have it, but we need to inform them that it's there and to give them the opportunity as whether they want the test, but mandatory for all patients who've already experienced miscarriage.
I'd just like to comment on that too as well, because we're already using this test. I use it routinely, obviously, for recurrent pregnancy loss evaluation, but whenever I have an IVF patient who's had a single euploid embryo transfer and they experience a loss, we're doing the testing in all of those couples. And we've started to do it, as Simon suggested, the problem may be even earlier on. So whenever we have a failed implantation, when a euploid embryo has been transferred, we use that as part of our evaluation as well. So we're already using it routinely in those other circumstances, but as Simon suggests, it may be worthwhile to consider providing that test to everybody who's undergoing IVF, if not all fertility patients. Next question is, in addition to M2 haplotype, was there any association between fresh versus frozen embryo transfer for preeclampsia phenotype?
I don't have the information on that. I don't think. But I can't see why fresh or frozen would make any difference. It's an embryonal coagulation problem, and that's what it's, because it's been a frozen embryo or not, I don't think it's really an issue. If anybody else would like to comment on that.
I mean, there are some differences between obstetrical complications in fresh versus frozen embryos. For instance, the low birth weight is significantly higher in the fresh embryo transfers compared to the frozen. But I'm not aware of data that suggests that severe preeclampsia is also related that way.
And just coming in on that, Bob, if I may, that's always fascinated me, given that we have a higher incidence in IVF with the existence of the M2 haplotype. We've never known whether it's actually, for example, IVF or the patient, and whether or not even this haplotype that's caused this potential significance in low birth weight.
Next question is for Nathan. What might be the explanation for the elevated frequency of M2 haplotype in the Estonian control samples?
Yeah, actually, I think Simon is more familiar with that data set than I am, so I'm going to have to defer to Simon on this one.
Okay, so this is quite complex because we know that there is a major difference between population groups, and in fact, the Northern European group is quite different. As is the Finnish group and the Estonian group are actually different to other European populations. So already there is in existence the variance related to ethnic groups. Now, I don't want to play ping pong here, but I'm going to have to refer you on to a really good paper by it was Markov, who was discussing this in a response to another publication, but it's out there and it's quite detailed. Rather than me go into it here, not least because I don't understand it all myself, but there is a significant database now on the variance in different ethnic populations, and it was Markov's RBM Online paper in 2016, and he particularly discusses the Northern Europeans as a response article. So if I can refer you to that, but it's not just the Estonian population, although the Estonian population has caused a problem in the publication relating to that and taking that into account, because also in that particular publication it's about using the controls too and looking at the controls. But I would urge anybody who's interested in this to look at all the various publications, and there's been quite a lot now on the different ethnic groups and the frequency. I don't know if that answers your question, but it's as best as I can do.
Next question, is this test coupled with screening for other mutations related to risk of thrombophilia?
Currently,
It's a good question. Sorry, Bhavini, go ahead.
I was just going to say currently no, but after Professor Fishel's talk regarding the other thrombophilias that he had mentioned, it might be interesting to see if any combination of those may be, in conjunction with the M2 haplotype causing these clinical pathologies.
Right, it will be interesting to look at the other thrombophilic markers to see if there's any further stratification amongst M2 carriers that would make it even more powerful.
All right, one of the most significant questions yet, I think. What's the cost of this test?
Right now, our standard fee is $200 per test. And as we're recommending it be done for both genetic parents, that would be typically $400 for a couple.
Okay, and that's the end of our questions. Is there any further discussion amongst the speakers that we can provide at this point for our participants?
I would urge people just to look at it. Not least, I think there's a relative R&D goldmine that we need to improve here. I'm not sure who the participants are, but they may well be predominantly IVF practitioners. But of course, the importance is population wide. And when you think you have a range from miscarriage to placenta-mediated complications, it's highly significant. And it's not my role to look at cost and that, but I think just from the pure medical science perspective, it's relatively new and I think significantly important.
You know, I think that one of the issues that's come up for me since we're using this test and identifying positives and treating them is that we need to educate the general obstetric gynecologist, because what's happening is that when I send the patients for obstetrical care, oftentimes the OBGYN wants to stop the treatment, and it's because they've never heard of this. So, you know, we've been trying to educate them as best we can that there are these significant complications later in pregnancy, like Simon has shown, that would really mandate that we continue the treatment all the way through the pregnancy, and in some cases, apparently, it's even been offered after delivery. So, you know, for me, we're finding more and more couples that the testing is appropriate for, and the question of how long to continue the treatment is one that we need to strictly reinforce to our OBGYN population so that the patients are protected, you know, throughout the pregnancy.
Can I just underscore that we have the care fertility group that have lost 2 pregnancies when the patient was discharged, as conventionally happens here anyway, is once you've got the positive scan, patient is discharged into obstetric care, and on the insistence twice that the low molecular weight heparin was ceased, the pregnancy was lost on both occasions. And so we send out, or the group sends out with the patient, a very clear clinical information document for their obstetricians, because it is, I mean, Bob's raised a very, very important point. It's crucial that they understand why we're doing what we're doing.
Another question, are there any webinars related to PGT-SR related to balanced translocation? Anybody aware of that?
We have one online that it doesn't focus on that, but there is a component within the webinar on LifeView that does talk about the ability to distinguish between carriers and normal embryos. I also have a webinar coming up that Bhavini mentioned on August 11th through the International IVF Initiative, where we'll briefly talk about that.
Another question, if you're doing a biopsy for PGTA anyway, is there any reason to not also request the M2 result?
If we're assuming that this is a case where one of the parents is a carrier, then the answer would be no. I don't think there's any reason not to include that information for the patient to potentially select an embryo that is not a carrier and avoid the necessity for the intervention of low molecular weight heparin. Obviously, if neither parent is a carrier, then it wouldn't be important.
So how about a situation where you've got a patient that's a carrier and the PGTA is being done at a different location? Is it still possible to send sample to genomic prediction and have the M2 test performed on the embryo?
Currently, no, but we're interested in collaborating with groups that might be interested in adding this test to their laboratory's capabilities. So if anyone out there is interested in working on this together, we'd be happy to look at the ability to test different amplification methods that might be in use elsewhere.
Could I just add, it also, in a sense, adds on to your polygenic work in the importance of that, is it kind of being forearmed and pre-warned about conditions, and that's one of the reasons why the polygenics is in there. But here, we don't really discuss it, but actually for the parents to know in the future that their child is a carrier could be important for that carrier in their own future pregnancies or in the management of their own health for various reasons that we've discussed that it could cause a problem. So actually, it's just having that information could be quite valuable.
Great.
Yeah,
Well,
that's interesting. Yeah,
I'm
sorry. Yeah, it's interesting because it's a similar outcome when patients know whether or not their embryo is a carrier of a balanced translocation in terms of their future fertility. So yeah, it's a good point.
Mm.
All right, I think that's all our questions. Thanks to all the speakers for those amazing presentations and for all the participants for their involvement and their questions. Just reiterate that we have a short survey once we sign off that if you'd all be so kind to fill out, we would greatly appreciate. Again, thanks for viewing this today, and everybody take care. Stay safe.
Thanks.
Thank you very much. Thank you.